Get your stem cells. Get your stem cells right here. We're going to fix you right up. You're never going to need surgery. You'll have a new joint tomorrow, right? Maybe not. Can't get no stem cell satisfaction. Hello, folks. Welcome back to the Orthopedic Health Nexus channel and podcast. My name is Dr. Lyle Ashberg. I'm a pediatric orthopedic surgeon and hip specialist. I thought that a great topic to cover would be something that's very big in the media these days, and that is stem cells. And I've titled this video, Can't Get No Stem Cell Satisfaction, because what really is available out there insofar as stem cells are concerned, and what is the reality about this type of treatment or potential treatment. So, look, we all want to live longer. We want to live healthier. We don't want to get older. We want to be stronger, thinner, and do the things that we did when we were teenagers. And we want to be pain-free. So we're looking for that fountain of youth. In reality, different individuals might have different goals. For example, the average person getting into their middle age, like me, might want to have a pain-free hip or knee joint if they're beginning to develop some arthritis, or the weekend warrior that's developed Achilles tendonitis or tendinosis that wants to play basketball like they did when they were teenagers and not have a rupture or something like that. And of course, then there's the high-level professional athlete that wants to avoid surgery, wants to get back in the game quicker and do it with the least possible delay. And of course, there's this new concept called minimally invasive. And so the impetus for wanting to seek out alternative types of treatment is multifold. And sometimes we'll do anything to get that, right? Drink things that the snake oil salesman suggests might cure all your ills. So, however, there is this potential for this so-called stem cell therapy in the realm of medicine, and it is the new and sexy thing out there that may cure all of our woes. And of course, where there is demand, there's the opportunity to make money. To give you an idea about the money involved here, this slide presented by Dr. Scott Rodeo at the Biologics Association in 2022 showed that in 2021, orthopedics and orthobiologics encompassed approximately $53.6 billion of total worldwide market sales, an 11.5% year-on-year increase from the year before, and 9.7% of that was orthobiologics. This means that approximately $5.2 billion were the amount of money spent on orthobiologics, and approximately 15.5% year-on-year increase from the year before. So you can see that this has the potential to be incredibly lucrative for all of the players involved in the orthobiologic space. The real question is, how real is this? I mean, how real are these things called stem cells? So the real purpose of this video is to try and demystify what stem cells really are, what's behind the hype, and clarify some misconceptions and highlight the reality of what this is all about. In other words, what works and what doesn't. I'm going to talk about this concept of orthobiologics, which is within the professional environment become the more acceptable term for this area of study and treatment, and the role of it in regenerative medicine. So again, getting back to that fountain of youth, the regenerating the old car back to its former self. And then how are we using these therapies, and what are the means to deliver them? And then I'm going to touch on briefly what's on the horizon, which in and of itself is a podcast or an episode to explore some of the cutting edge stuff. So let's talk about what is regenerative medicine. And one way we might define it is what the FDA says, because ultimately they regulate all types of products that are utilized in human health in the United States, amongst other regulatory agencies. And to define it, regenerative medicine includes therapies that repair, replace, or regenerate human cells, tissues, or organs to restore normal function. And it includes things such as cell-based therapies, i.e. the stem cells we're talking about, or progenitor cells, gene-based therapy, which includes a multitude of different things and continues to expand and is probably one of the really cutting-edge, exciting fields in medicine in general. Tissue engineering, such as the use of scaffolds or tissues that support regeneration. And then, of course, biologics, which is sort of an overarching term that entail or consist of any number of the aforementioned things, but may also include things such as cytokines, platelet-rich plasma, etc. Now, what led to excitement in a lot of this stuff is that these effects were found to be true in preclinical studies. So meaning ex vivo, or outside of the body, or in the laboratory, or even in animal models that shown that these biologics had a positive effect on tissue healing. And they work by naturally leveraging the body's natural physiology. And it works through cellular and molecular events. So a little bit of a high-level definition there, but it sort of gets to the crux of a lot of these matters, and where we're trying to use the biology of the person or the person's tissues at both the cell, tissue, and molecular level to affect an outcome, a positive outcome. And in orthopedics, we're dealing with things that include bone, muscle, tendon, cartilage, and the like. But the real drive here is to try and get healing of tissues that are notoriously difficult to get to heal, such as cartilage, such as structures like the meniscus or the cartilage inside the knee, tendons, or even muscle injuries. And we often talk about the holy grail of orthopedics being joint cartilage, which, when it goes away, is essentially what arthritis is. So the loss of cartilage in a joint, such as the knee or hip or shoulder, results in this thing called arthritis, where the shock absorber of the joint, or the thing that makes the joint move very smoothly, the cartilage, or the articular cartilage to be specific, is lost. Once that goes away, you start to get pain. And you often hear about this thing called bone-on-bone arthritis. And I tell my patients this is like losing the rubber on your car tire. So the amount of tread that you have really determines how well your joint is doing. And the reason that this is the holy grail is because you're only born with one set of tires, and cartilage has a very, very low capacity to heal itself. And so if we can find some biological mechanism to help heal the cartilage and some of these other structures that have poor healing capacities, that would be gold, right? The orthobiologics that we have available to us in orthopedics at the moment include things such as platelet-rich plasma, or PRP, things that we can aspirate from other sources, such as, and concentrate from other sources, such as bone marrow, or adipose tissue, which is fat tissue, or perinatal sources, such as amniotic tissue, the placenta, or the umbilical cord. We also use other things in orthopedics, such as extracellular matrix, which we use as scaffolds to allow tissue to grow in. And we may be able to, at the molecular level, we may be able to isolate some of those chemicals that stimulate growth and regeneration around them, because there are very complex mechanisms at the molecular level of the cell where the cells talk to each other and say, hey, I need some healing in here. I need some blood vessels in here to bring me oxygen, etc. So, and of course, there's always pharmacology or drugs, which indeed work at the molecular level to affect a change in the tissue environment. So since I've been stuck on this definition thing, maybe what might be pertinent is to define exactly what a stem cell is. And it's a very specific thing. It's a cell that's capable of self-renewal, so it can regenerate itself, asymmetric cell division, which gets a little bit complex, and multi-lineage differentiation potential, which means that it can be anything. So to define the two different types of stem cells, the one type is the mesenchymal stem cell or the mesenchymal stromal cell, which are commonly known as the adult stem cells. And these cells are multipotent, meaning they could differentiate into a multitude of different cells within the same germline of tissues. And when we talk about germlines, we're talking about things that are present in the embryo that have a certain fate. So for instance, we talk about the ectoderm, the endoderm, and the mesoderm. Ectoderm tissues would become skin or nervous system or eye. Mesoderm would be things like the musculoskeletal stuff like muscles, bones, and connective tissue. And endoderm might be things that we would see such as digestive tract lining, respiratory system, things like the liver and the pancreas. So the multipotent mesenchymal stem cell will typically be able to develop into any cell type within that particular germline, whereas the embryonic stem cell can essentially can evolve into anything, any type of tissue or any type of cell, and those are what we call pluripotent, which means they could really be anything. And so now that you understand some of the definitions, we can apply this knowledge to deciding on whether we really are getting stem cell therapy, and more importantly, are these biologics doing the things that they're promised to do or that we hope they'll do? Now, embryonic stem cells are very exciting because of their pluripotential nature. They could become any tissue and may be very useful in treating some really difficult diseases such as congenital heart failure or things like certain neurologic conditions. But as most people know, this is a contentious societal issue, and the debate around whether we should be using them at all remains a hot topic. And so I won't focus on that. But when we come to the adult stem cell component of things, again, I come back to, are the cells that we're getting really stem cells? Are we getting enough of them? Are they doing the things that we want them to do? And is the advertising and promises that are being made by a number of practitioners real? So given the definitions that I mentioned, it is likely that the cells that we harvest using traditional and approved means, that is to say, from bone marrow or adipose tissue, probably don't meet the true definition of a stem cell. Indeed, the cells that we get from these harvests are probably in such a small amount and are so mixed in with a bunch of other stuff, even when it's centrifuged or spun down or concentrated, that it's unlikely that we get a true stem cell representation at all. And so the definition over time has changed. With our current means in the United States, we are probably only getting what some would call connective tissue progenitors, or CTPs. And those cells are, as I mentioned, heterogeneous. They're a variety of different cells, which can proliferate, but could also induce generation of progeny or additional cells, and have some capacity to differentiate into one or more of the connective tissues. And what's important about regulation in the United States is that the FDA does not allow the isolation and subsequent culture expansion of these small amount of cells that we tend to get out of traditional means. And the reason that the FDA is so stringent about this is that there is very little high quality evidence to support the use of so-called stem cells or even orthobiologics. And there have been some complications as people have used so-called stem cells that relate to the harvest, manipulation of, and safety of these cells. Now, it's important to continue with this theme about the FDA because the the utilization of so-called cell-based therapy, or even orthobiologics, and as it relates to regenerative medicine, falls under the purview of the human cells, tissues, and cellular and tissue-based products, or HCT/Ps regulations. And the way that the FDA regulates this depends on what's agreed upon to be the level of risk involved in using these products and the degree of manipulation to which these cells are subjected. And again, that goes back to this topic of cell culture, expansion, or manipulation of the cells, such as one might do with fat cells. And currently, the FDA only allows stem cell products, or has only approved stem cell products in the United States that consist of blood-forming stem cells, or otherwise known as hematopoietic progenitor cells, that are derived from umbilical cord blood. And they are only approving the use of these in disorders that affect the production of blood or blood-forming units, such as red cells, white cells, and platelets. And typical conditions that you might see this are in things like aplastic anemia, or severe combined immunodeficiency, or after things like chemotherapy, where the chemotherapy basically wipes out the person's bone marrow and they need a bone marrow transplant. So stem cells are one way to enable a bone marrow transplant and get it doing its job again to form those blood units or components. And so those are really the only approved use of, FDA approved use of so-called stem cells. An extension of this is that they also say that any product that is purported to be a regenerative medicine product, including stem cells, exosomes, which I'll talk about a little bit later, and other widely promoted products such as adipose tissue, and specifically the stromal vascular fraction of adipose tissue, human umbilical cord blood, Wharton's jelly, or amniotic fluid, should know that none of these products are approved for the treatment of orthopedic conditions such as osteoarthritis, tendonitis, disc disease, tennis elbow, back pain, hip pain, knee pain, neck pain, or even shoulder pain. And I will provide a link in the show notes to the FDA statement about this, which is fairly clear. Now, obviously, humans being innovative have been able to manipulate those definitions slightly, such that we're able to use certain things in an off-label manner. And it is important to note that the FDA does not regulate the practice of medicine. It regulates products that are used in medicine. And it is not uncommon for us as clinicians to use products in a so-called off-label manner, or assuming that we provide patients informed consent that the product is off-label. And particularly off-label means that the FDA has approved the product for another condition. It is generally shown to be safe and effective in that approved condition. It has some reasonable scientific basis or justification, and sound clinical judgment is utilized by the practitioner. An example might be the use of platelet-rich plasma for hip arthritis or shoulder arthritis. Now, we know that it's generally approved for the use in knee arthritis, but not for hip arthritis. And so if we are going to use that product in a patient in another joint, then we need to inform the patient that this is off-label use, or we might say that the data on this are limited. One of the reasons that I said that what we're using today are not truly or don't truly meet the definition of stem cells is because of the heterogeneic or the mixed nature of the cells that we get out of these aspirates. And one thing that folks are now doing are going to seek true stem cell treatment in other countries, leading to this concept known as medical tourism, where you go somewhere else to get your medical treatment. And I happen to have personal experience with folks that have gone off to Mexico, for instance, where stem cells are being cultured and these are the patient's own cells being cultured and then being re-injected. Now, the problem with that is that in a lot of these countries, the regulation and the management of these tissues, and they are tissues, are not as stringent as the United States, and that leaves the patient wide open to all kinds of risks, both anticipated and unanticipated. And so, generally speaking, in our medical community, we discourage that because of the lack of consistency and oversight and sometimes regulation. So what I'd like to do is stick to the terminology of orthobiologics here, given all of the limitations of using the so-called stem cell moniker that is being utilized fairly freely in the common press and even in some advertising and marketing campaigns. So we'll stick to the terminology orthobiologics, which is being espoused by most of the major orthopedic associations that are in the United States today. So what's available out there insofar as orthobiologics are concerned? The first one I touched on briefly was platelet-rich plasma, or PRP. And what this is the patient undergoes a blood draw of a small amount of blood that is then put in a centrifuge and spun down, and the platelets, which are part of the blood, are isolated in a small volume of plasma. That's why it's called platelet-rich. And within that plasma, there are also other things that are in there, including various proteins that may decrease inflammation, or decrease pain or reduce pain, and expedite some of and recovery and healing of some of the soft tissues. Now, to remind you, a platelet is a small non-cellular particle that is in your bloodstream amongst the red cells and the white cells that is used in clotting. So when you have a cut or something like that, the platelets come in, and as part of the clotting mechanism, they help shore up that clot. And they also release cytokines or various molecules that tell other cells or other tissues to come and help heal this area. And so obviously, this is where the idea that they may help in regenerating or healing tissues might happen. They also have an effect on the immune cells, telling them, hey, listen, there may be invaders here, come and help kill any invaders, but also they modulate inflammation. And so they secrete these signaling molecules that work in an as anti-inflammatory mediators or immunomodulatory proteins. And as I mentioned, they also secrete growth factors and cytokines. Generally, the two forms that have been utilized are leukocyte-rich PRP versus leukocyte-poor PRP. And this refers to having an increased amount of white cells or lower percentage of white cells, respectively. It's generally low risk and potentially high reward. Now, why wouldn't one use it? And this is where the biggest points of contention come in modern medicine at the moment, is that there's a lack of standardization. There's a lack of standardization not only in the terminology that we use to describe this, but also the formulation. In other words, what is withdrawn if you use one type of product or one manufacturer's product or another manufacturer's product, you may get a different concentration of platelet-rich plasma. There may be more or less contamination, and I mean that in the terms of more or less white cells or red cells in the mix. The protocols that are used to spin these tissues down differ between manufacturers, and then how it's delivered may vary from manufacturer to manufacturer. And so there's inconsistency. There's also inconsistency in what studies show that platelet-rich plasma does or how effective it is. And again, that has led to some confusion and a lack of standardization in not only the protocols and material that we're using, but also in the outcomes. Now, the second con, or negative to platelet-rich plasma, and all of the orthobiologics in general, are that PRP is generally not covered by insurance and is usually out of pocket. Other considerations is how many platelets do you need, and there is some data that suggests a certain amount. How many times should one inject this? How many times can you inject it? Is there fall off over time as people get older? So again, these are some of the considerations, and I'll touch on these briefly a bit later. So what does the science show about PRP? Well, there are differing outcomes, and there are multiple studies that show, on the one hand, really promising results, whereas on the other hand, the results are not any better than placebo, or very limited effect or benefits. Generally speaking, the studies that have shown very encouraging or encouraging results are the treatment for the things like treatment of things like tendinopathy, or which refers to inflammation of various tendons, whether they be the patella or the knee tendon, or the hip abductor tendons, or to some extent the rotator cuff disease. And there is some data that shows that it may help improve the symptoms of osteoarthritis. But again, this is inconsistent. And so the clinical evidence is mixed. And what seems to be consistent, however, is that the clinical evidence for tissue regeneration is lacking. So the consensus generally in the medical community now is that PRP seems to be more of a symptom modifying and not a structure modifying treatment. Now, in my own personal experience, and particularly in the hip area, we are finding that these patients who have tendinopathies, for instance, in the abductor or the hip tendons, that patients generally do pretty well. And it may take some time for them to get better, but generally speaking, when you combine it, especially when you combine it with other treatment modalities, the results seem to be favorable. And so what this means for the patient is that sometimes they can delay having a surgery, and in a lot of instances, even preclude them from having a surgery. In other words, they can avoid much more invasive treatment. So because it's low risk and relatively high reward, especially when combined with other modalities such as physical therapy and activity modification, etc., this is a very useful adjunct to patients' treatment options. The second major area of orthobiologics that is approved for use in the United States is bone marrow aspirate. And what we get out of the bone marrow aspirate are these so-called mesenchymal stromal cells, or MSCs. And the way that is obtained is by using a large needle, and it is a fairly scary-looking needle, to be honest, to aspirate bone marrow from a bone somewhere. Most commonly, it's the pelvis or the iliac crest, but it can be taken from other areas such as the tibia or in the end of the femur. But generally, the iliac crest is the most common place we take bone marrow. And then it is spun down in a centrifuge, similar to what happens with PRP, in an effort to try and concentrate those stem cells as much as possible so that we're getting a larger effect. And it can then be injected into a joint or into area of tendon attachment. It can be used in surgery. It can be mixed with some other material to help with bone healing and things like that. And the way that it seems to work is through what are called paracrine effects. So what paracrine effect means is that these chemicals that the stem cells elute modulate their local environment to promote healing and repair rather than directly taking part in tissue regeneration. And this paracrine effect may also work by stimulating angiogenesis, which is stimulating the growth of new blood vessels into an area, which again brings in various healing chemicals or molecules in the bloodstream that work in the healing process. They also may have an anti-inflammatory effect, very similar to that notable for PRP. So again, BMAC, or concentrated bone marrow, has very similar outcomes to that noted for PRP, and again seems to be have more of a symptom modifying effect than a structure modifying effect. Again, there are studies that are for and against, meaning positive outcomes relative to placebo or other treatment modalities for bone marrow. And again, it's inconsistent, which is what leaves the FDA having to make the recommendations that it does. Two other topics that I wanted to discuss in the orthobiologics space include hyaluronic acid as well as glucosamine and chondroitin. Now, hyaluronic acid is a naturally occurring substance in synovial fluid, and it is largely responsible for the viscosity of the fluid, which allows it to help lubricate the joint, provide a shock absorber, and nourish the cartilage in the joint. And so the thinking behind these injections, and it's usually a series of 3 injections, sometimes less, depending on the manufacturer, is that it'll replace the natural function of the synovial fluid in an arthritic joint where synovial fluid is lost or diminished. And as I mentioned, it's used for viscosupplementation. And the general indication is to treat osteoarthritis of the knee. However, the results and the efficacy of this substance is found to be mixed, in that there are, again, studies for and against, where some studies show improvement in pain and function, generally up to about 6 to 12 months, with relatively rapid onset within the first few weeks after injection. And it is used in patients where other modalities have failed, such as anti-inflammatory medications and physical therapy, etc. It's generally not as good as steroid medication, albeit with probably fewer side effects, and it's generally pretty safe, with occasional mild local reactions such as swelling, warmth, or maybe some redness. But again, the data doesn't necessarily support its use, and the American Academy of Orthopedic Surgeons does not recommend this for osteoarthritis. The second concept that I wanted to chat about is oral supplementation with glucosamine and chondroitin. And these are 2 proteins that are naturally found in the cartilage matrix and act as structural components of the cartilage matrix. And again, the thinking is if we can take this protein, encapsulate it into a pill form, and take it as a supplement, it might go to the joint and provide some repair to those missing cartilage proteins. However, there is no data that shows that this actually happens from a structural perspective. Some clinical studies have shown that it may have some effect in reducing the pain in osteoarthritis, and maybe to some extent helping with function. But again, the results are very mixed. They're often used as a combination with glucosamine and chondroitin combined together in a single pill, and they're pretty safe, well tolerated, with occasional gastrointestinal side effects. However, again, no great data or inconsistent data that show these things help better than placebo. I'd like to briefly touch on something that has generated quite a bit of interest in the press as well, and this is this concept of exosomes. So if you think about how a lot of these tissues work, or orthobiologics work, is through molecules that, or proteins that talk to other cells and other tissues to create the effect or to induce a physiologic response in the native tissue. And exosomes are signaling molecules that are encapsulated in and are released by extracellular vesicles. What that means is these signaling molecules are in these little bubbles that are in the cell that are then released into the external environment, and they have an effect on telling the other tissues, hey, we need a healing process to start happening here, and because there's an injury or we may need a certain effect. And these molecules can be isolated and purified and then injected in one form or another to create an outcome. And they include things like microRNAs, which is an exciting topic here, and a group of proteins that switch various other proteins on or cause an effect in gene modulation or expression, and they are the ultimate signaler of the effect of the desired effect that the body is trying to achieve based on the circumstances. And they too work on this paracrine mechanism. What's useful about these particles are if we could isolate them and use them at their purest form and at the optimal dose and in the optimal place and in the optimal circumstance, we may get the effect without having to go through the cellular harvest mechanism. And indeed, we may not even have to go through creation of a so-called stem cell. In fact, they would be even more specific and targeted and will allow for a much more personalized effect. However, these are currently not FDA approved for general use. They can be used in an experimental setting, but require special dispensation from the FDA to do so. There is also gene therapy, which I touched on briefly in the beginning of this podcast. And as modern medicine has begun to utilize gene therapy to affect various conditions such as sickle cell anemia and various childhood abnormalities, so we have learned to utilize the gene to, again, create proteins that affect outcomes in various tissues. And generally speaking, gene therapy have been found to be important for things like improving vascularity, cell matrix synthesis, which is what cartilage cells are suspended in, is the matrix. They can help with tissue healing or decrease persistent inflammation. And then, of course, there are exciting things like CRISPR, which, again, I will touch on a bit later. Getting back to what I discussed regarding the use of PRP or bone marrow aspirate or adipose tissue for that matter, are some of the risks involved. And generally the risks are pretty low. So those might include things like infection or problems at the site of aspiration, such as in the bone marrow. Some patients may develop a large hematoma or an area of bleeding under the skin. And there have been some people that have actually died from infections related to tissue harvest. Why all this hullabaloo about terminology and limitations, etc., etc.? Well, in the media, there's oftentimes a lot of hype about potential groundbreaking, cutting-edge biologic treatments that may be the cure-all. And there are a lot of clinical practices that will hype these things up and use things like regenerative tissue, minimally invasive stem cell therapy to treat your arthritis and get you back on the road or get you back playing as soon as possible next week. Well, I think we need to be honest with our patients and ourselves as clinicians about what we're offering, as well as their efficacy and the risks and benefits of these things. And there is a lack of consistency, as I mentioned, in the terminology that we use. In other words, for instance, we can't even agree on should we be calling these stem cells, what exactly are stem cells, and does it really fit the definition of what we intended to use, or is it just sexy jargon? We need to be consistent about the variability of the formulations that we've got. So I often tell my patients, we haven't even defined yet what the recipe to make the cake is. And more importantly, we don't even know what pan we're going to use or what temperature the oven needs to be on. So although it does seem that cell-based therapy or biologics will have an extremely important and positive role on tissue healing, pain modulation, and function in patients, we haven't quite figured out what the formula should be yet. In addition, there's a tremendous amount of variability in the apparatus that is utilized to collect these tissues, and we haven't identified all the markers that have the best potency or the best utility in treating a lot of these problems, such as which are the most potent, which are the most biologically active. And all of this is happening in a very, very complex environment, and they're with multifactorial effects. So in other words, which molecules are actually doing the job, and what is the concentration of the molecules that are necessary? You also got to look at the tissue that it's working on. Or is the molecule that you're providing, molecule A that you're providing, adequate to treat the tissue B in the circumstance of C? And we can't forget that there are patient-specific variables that come into play, such as what is my expected function and what are the goals that I'm trying to achieve? Am I a pro athlete? Am I the average Joe or Jill that wants to be functional to this level? What are the goals of treatment? Should it be to decrease inflammation? Will it help? Do I need the help with tissue healing or tissue synthesis? Do I need increased vascularity? What's the metabolic health of the person that is being treated? What is their overall health? And there are other covariables such as smoking, age, sex, and then in orthopedics we deal with mechanical factors, that is to say limb alignment or deformity. All of these things come into play when we consider the biologics of orthopedic treatment. And the American Academy of Orthopedic Surgeons have provided some clinical practice guidelines related to the use of these biologics in things such as knee osteoarthritis, rotator cuff pathology, shoulder osteoarthritis, and osteoarthritis of the hip. And generally speaking, the guidelines are very limited to what we can expect our effects to be. Similarly, if you get into the professional realm, NBA provided a Orthobiologics consensus statement in 2020, which follows very closely what the American Academy of Orthopedic Surgeons put out in 2013. And I will put those in the those links in the show notes below. So what is the future of cell-based therapies? Well, there is ongoing research into what is the most effective formulation necessary, where there is consistency between centers, between products, and certain standards are set such that we're able to study these and really demonstrate effectiveness, cause or effect, or actually improvement in our patients relative to so-called placebo. Gene therapy, as I mentioned, is really exciting in the realm of CRISPR, which is CRISPR-Cas9, which is the ability to remove certain portions of the gene and then insert another coding section in a very customized way, I think is likely to have a huge impact going forward and is cutting edge. Exosomes, which are not yet approved by the FDA, but ultimately contain those molecules or proteins that result in major effects without the need for cellular harvest, are likely to become really important in the biological treatment of wellness and orthopedic conditions. Amplification of cells is likely to be something that will be regulated. But again, what formula or what ingredient in the recipe is necessary for the most efficacious outcome? One of the big things I've touched on as well here is patient-specific treatment or patient-focused treatment. And this is becoming a big thing in medicine as each individual's physiology, biology, metabolism, and genetic makeup really offers the opportunity to do personalized medicine. And I think with artificial intelligence, which allows us to crunch huge amounts of data, which will allow for prediction of what treatments will and won't work, is a really exciting time to be in medicine. So in conclusion, and the takeaways at this time, orthobiologic therapies may help manage orthopedic symptoms, but they're not a cure-all, and generally speaking, they tend to be symptom modifying and not necessarily structure modifying. I think we need to be wary of over-promising and be realistic about outcomes and the things that are possible with the current orthobiologics that we have at present. And I think the honesty needs to be both at the level of the patient and also the level of the doctor. It should be very clear that orthobiologics are not a panacea and are not necessarily the magic bullet, and they are not a substitute for traditional surgical treatment and even non-operative treatments such as physical therapy, anti-inflammatory medications that are well supported by long-term data and clinical study. With that said, I think that they can be an excellent adjunct and be complementary when used in conjunction with other therapies such as physical therapy, exercise, good nutrition, and surgery, and even in surgery. And my final thought on this is, with further research, stem cell therapy, actual stem cell therapy, might offer more, but for now, these treatments should offer us a better quality of life and function, but they do not necessarily reverse existing joint damage. I think this is an incredibly exciting field, and it is being pursued actively by multiple different multiple different specialties and across multiple disciplines. And I think it has the capacity to really help us live our best life. With that said, I'll see you next time. Cheers.